Okay, good morning. I'm going to go over lower extremity regional anesthesia today. Jump right into it. So I'm going to start with the fascia iliaca block. So with these blocks, you really just want to know the anatomy. You want to really, that's 99% of it. So I'm really going to just focus in on where the needle might be and what the implications are. So the fascia iliaca block, the hip, anterior thigh, and knee. So we have the lumbar plexus, which is the nerve roots from T12 to L5. So the ventral rami from T12 to L5. And the largest branch is 2, 3, 4, it's the femoral nerve. Little dermatomal look there. You have the lateral femorocutaneous on the outside of the hip and lateral thigh. And then the anterior femoral cutaneous nerve, and the saphenous comes off of there, becomes the medial tibia. So the lateral femoral cutaneous nerve is the sensory nerves from 2, 3. Okay, so 2, 3, 4 is the femoral nerve, 2, 3 is the lateral femoral cutaneous, and that sensation from the iliac crest down the lateral portion of the thigh. The lateral femoral cutaneous nerve emerges from the lumbar plexus and travels lateral to the psoas muscle, crosses the iliacus muscle deep to the iliacus fascia. We also have the obturator nerve, which is for the medial thigh. There's some cutaneous, there's the internal and external branch, and also innervates the adductors. So picture in the upper left corner of the screen as a picture of the fascia lata, fascia iliaca, two fascial planes. The fascia iliaca lays on top of the iliopsoas muscle. So picture your psoas muscle, which is the hip flexor, inserting on the femur, and the iliacus muscle, which lays inside the ilium, kind of becoming one muscle together before they insert on the femur. And they're covered with a piece of tinfoil-like fascia, which is the fascia iliaca. So your needle's going to pierce that fascia iliaca, and you're going to feel it just like you feel a flavum when you go through with an epidural needle. You're going to feel a pop. And then you don't want to be intramuscular, but you also want to make sure you're through that fascia. So that's the key distinction. You're in a potential space. Most of the blocks we do are in a potential fascia, and that will open up with spread.
Tonight I'm gonna be in medicine.
Iliopsoas muscle, showing its origins and insertions. So again, iliacus inside the ilium, and the psoas coming off the vertebral bodies, all going to the femoral neck and head, lesser trochanter, to be a hip flexor. So there's two approaches to the fascia iliaca. I prefer one that's known as the NY Sora technique, which is sort of like a femoral block, but a little bit lateral. But I'm gonna show both. So again, the upper left picture here, yellow, is kind of showing where your local anesthesia spread is gonna be. So you're gonna get spread around the femoral nerve, back to the lateral femorocutaneous, and to the obturator in a true fascia iliaca block. And it's a high volume block. So when you use high volume, you got to cut back your concentration. So just think of it as ropivacaine comes in a 30 ml bottle of 0.5. It's safe to use 30 mLs of 0.5 ropivacaine or bupivacaine. It's probably even safe to use 40 mLs. I try to keep to 30 when I can. But if you cut that in half with saline, now you have 60 mLs to play with. So if you're doing 2 blocks or 2 sides, always keep that in mind. With the amides, and it's not so much patient weight dependent as we used to think. So we just try to kind of stay in there to be safe. And remember, ropivacaine is 3 times safer than bupivacaine. So you have the choice. One day you'll be teaching residents or whatever, say, people are going to be running around the hospital with needles doing nerve blocks. Would I not want them to be training with a drug that's 3 times safer? And they discovered that in animal models, they infused intravascularly bupivacaine and ropivacaine, and the bupivacaine animals coded at 1/3 the dose, and they were very unresuscitatable versus ropivacaine, they were able to get them back. And so what's the downside to ropivacaine is it's probably less potent. So when Neuropin, which is ropivacaine's brand name, came out, it said less motor block. That was kind of their advertisement, less motor block. But that's just a function of it being probably less potent. But you can get a surgical block. You can do your AV fistula with 0.5 ropivacaine, but it won't be as dense as bupivacaine. And probably that will take away from the duration at touch, because they're both long-acting amides, but because it's less potent, it probably, the number of milligrams are the same, but the drug's less potent, so it may last not as long. The bottom right picture here is showing what they call the bow tie sign. So if you look at the hyperechoic, so you got hyperechoic, hypoechoic, anechoic, this terminology here. So the hyperechoic ilium, that's the pelvis bone there. And this is a striated muscle on top, the iliacus. And then you have the fascia iliaca over the iliacus muscle. Above that are two muscles, they call this the bow tie sign. You see how this could be considered a bow tie in the bottom right picture. That's your sartorius. Remember the sartorius muscle, it's the longest muscle in the body. It's called the talar muscle because talars, you need that muscle to do this motion, which is the position talar sitting. And it inserts up here by the ASIS, and it's connected right here by the inguinal ligament. So, Hopard's ligament or something. But the inguinal ligament, the sartorius is attached to, and the internal oblique. So picture your tap block, right? You got your external, internal, transverse abdominis. The internal oblique is joining the inguinal ligament, and caudad to that, the sartorius, and this is the bow tie sign. And so what you do is you take your needle through the sartorius muscle, and the best way to find this is to put your probe. I mean, everyone's seen the sartorius muscle. We do adductor canal blocks, but you look up in the inguinal area, you see a round muscle. You know, you'll see the iliopsoas and then the sartorius lateral to it, and the tensor fasciae lata muscle lateral to that. When you're on the sartorius, you just rotate your probe 90 degrees, and you'll get this bow tie sign. So rather than just pick a random spot, find your sartorius, make it a circle, turn the probe 90 degrees, and see the sartorius and the internal oblique connect at the inguinal ligament, and you bring your needle through the sartorius in plane, and you'll feel a pop as you enter the fascia iliaca, and you'll inject your 50 mLs, and it will spread north to the lumbar plexus. That's the idea. So first you scan with the probe in the opposite orientation here, find your vessel, stay away from them, get over the sartorius, rotate it into this plane, and then come in plane from caudad to cephalad, go through the sartorius muscle, pop through the fascia iliaca, and inject the 40 to 50 mLs. If I have a lean patient, I'll use this technique. Here's another look at the iliacus muscle, the sartorius, and the internal oblique, the needle coming in, popping through the fascia iliaca and injecting. And then as you inject, you create a space, and you can advance the needle into that space you create. That's like a hydrodissection technique where you know it's safe to move the needle in that direction. Now there's an infrainguinal technique, and this is like so easy, and this is the one that I reach for. So we used to do femoral nerve blocks. We put the probe in the inguinal ligament, we see the nerve artery vein, and I'll discuss how to do that later. I have slides on it. This is just, you go a little more lateral, and you do the same kind of technique. So I'll show you some slides on that. So it's the same probe position as a femoral nerve block. The transducers move lateral until the sartorius is identified, and then we pop the fascia iliaca and inject the same volume. So here's our fascia iliaca over the iliopsoas muscle. So we have the iliacus and the psoas forming the iliopsoas, which is a hip flexor. It's covered by the fascia iliaca. This is the sartorius muscle, and our needle's going to come in and inject, and we're gonna get a great spread here. And the local is gonna go medial and get the femoral nerve. And the femoral nerve is gonna cover the osteotomes to the hip. Right, so we're doing hip surgery. This is great for a hip fracture patient. The downside to this block is you get quad weakness. So if I give a fascia iliaca and the patient gets out of bed to go to the bathroom, plants their foot, their knee will buckle and they'll fall down. And we've had falls at this center and every center across America. And so we can't let history repeat itself. We used to do femoral nerve blocks for total knee replacements, and we had a lot of quad weakness as an issue. Now, I'm suggesting this to you for the hip fracture patient because they're not ambulatory the first day. And by getting the femoral nerve, you not only get the osteotomes to the femoral head and neck, but you also get the quad spasm that comes from the fracture. So when your bone is fractured, your body is like tensed up because the bone articular spikes are rubbing into each other and everything tenses up and there's a lot of quad spasm. So the fascia iliaca is a no-brainer for me for all our hennies, fractures, all our gamma nails. So I come in the room, I give them a little something to relax. I put the probe on, I put 40 mLs in this technique, and then I put them on their side and put the spine on them. And that way, they're gonna have a much better night. These are patients prone to delirium, so if you can avoid opioid exposure, it's really good. And it's effective. It's effective for a gamma nail. It's covering the incision and it's covering the osteotomes. So by preventing opioid exposure, you might prevent a delirium. You'll give them better pain scores, patient satisfaction. And as your spinal wears off, you have a little more coverage because you have this long-acting block in there. Not usually an issue, but it's another piece of it. Now, traditionally, fascia iliaca gets the obturator, but it's not covered with this technique very well. And that's fine, because we don't really need obturator coverage for what we're using it for. So this is the probe medially. You have the femoral artery, right? So your iliac is the femoral artery, and the femoral artery becomes the superficial and deep femoral. The deep femoral artery goes to the bone and muscle. The superficial femoral artery, we all know from the adductor canal block, it runs down the medial thigh, through the femoral triangle, goes under the sartorius, goes through Hunter's canal, and becomes behind the knee as the popliteal. If we follow the femoral artery to where it's the common femoral, that's where you do this block. If we're more distal and you see two arteries, the superficial and deep, the femoral nerve has spread out like my fingers here. There's anterior and posterior divisions. And it's hard to get all the fibers. But if you follow the two arteries back to the common femoral, it's more like my wrist and everything is together. So the first part is to find an artery, which is so easy to find, scan proximally until it's one artery. And that's when you'll get this view on the far right, which is the femoral artery and the femoral nerve all together, sitting on the iliopsoas muscle with the fascia iliaca over the top. Now this circular muscle to the left on the upper part of the right image is the sartorius muscle. So then we move our probe a little bit more lateral and we'll get this view, sort of like the middle. If we went even more lateral, we would get this view, and this is where you see tensor fascia lata. This is where the lateral femorocutaneous is sometimes seen, but we don't need to inject it there. But this is that sartorius muscle. The sartorius muscle is sitting on top of the iliopsoas. So our needle is going to go in plane through the sartorius, popping through the fascia iliaca, and then we're going to hydrodissect towards the femoral nerve. And you don't need to bring your needle towards the nerve, which is a good thing for safety. I had a friend at another center who had an uneventful femoral nerve block, and the patient had 0 out of 5 quad for the rest of their life, and it was a lawsuit. And he doesn't even remember the block. It was with a resident, it was like uneventful, and the patient had neuropraxia. So if I can inject here, and I'm nowhere near the nerve, I'm gonna be happier. Then you don't have to harass the nerve. All right, so that's the two approaches to the fascia iliaca, great for hip fractures. You also may want to do it if you couldn't get to a PENG for a hip scope and the patient had a lot of pain. Sometimes the hip arthroscopy patients have a lot of pain. And I don't block them pre-op, but sometimes post-op. I'll look at them and say, we gotta do something here. And they can get either fascia iliaca or PENG. I personally know of a CRNA who had a PENG block for hip arthroscopy, and it was very effective for them. And that's a good source, right? Like that's somebody in the know who says like, this really helped. So I think that PENG, which I'll discuss now, is good for the hip arthroscopy patients and the hip replacements. So total knee replacements hurt like the dickens. Total hip replacements don't hurt as much. And you'll notice our surgeons here aren't very pro-block for their hip replacements because they see their patients doing very well. They look good in recovery, they go home, we give them Celebrex, Tylenol, Dextran, they use minimal opioids. But you may have a patient or a surgeon that wants it, or a patient that you think is appropriate, and you can offer this PENG up. I will say that these techniques come out and they outpace the data. Everyone's all excited about a new block, and there's really not good endpoint data that says like, hey, this is really reducing opioid consumption or improving mobility, things like that. So be careful about jumping on the bandwagon every time. Oh, the QL6 came out. It's like, oh, let's all do it. Sticking a needle like through the aorta again. And it's like, what are you doing here? And you take 45 minutes and you're like hubbing a 6-inch needle, and there's like no outcome data yet. So I think people love to come up with new technique. They love to get published. They love to talk about the conference, but a lot of times I've noticed that then those blocks fade away and you never hear about them again. All right, so let's talk about the pain. So the pain nerves of the anterior capsule of the hip, it provides pain reduction while preserving motor function. So that's the real key here, is that fascia iliaca was going to give you a femoral nerve block, and this is not. It's good for intertroch femoral fractures, femoral neck fractures, pubic ramus fractures, acetabular fractures, and hip dislocations. This is a curvilinear probe. Curvilinear probe gives you a view like this rather than a view like this. And so blocks like the IPAC or QL or the PENG, you grab this, you don't have to chase your needle. Everything is in view. All right, so the anterior hip capsule is innervated by the femoral nerve. The articular branches innervate the anterior lateral hip. The obturator nerve, the articular branches innervate the anterior medial hip, and the accessory obturator nerve contributes to 10 to 30% in the inferior medial aspect of the hip capsule. Right, and this is your lane, so this is what you need to know. Like surgeons, they have their lane, nephrologists have their lane. You need to know this. If you're going to be sticking a needle in there and doing a PENG block, you should know this. So take a look at these fibers. These are what you're blocking. All right, on the upper right is an ultrasound view. The hyperechoic line of bone is the ilium. You have the iliopubic eminence and the anterior inferior iliac spine. And laying on the ilium is the psoas tendon. So our needle is going to come in. Now remember, right here is a femoral nerve and artery. And there's like cases of like femoral nerve damage from PENG blocks because people are not looking. You want your needle to come in a plane where you're not going to interact with the vessel or the nerve. So just when you first put your probe on, I always throw color on, look for vessels, push down, see if anything's compressible. That way I don't get a vascular puncture, or even like interscalene. A lot of times you'll see nerves in the anterior scalene muscle that if you look for, you say, okay, I can avoid these in my trajectory rather than go right through the long thoracic or dorsal scapular. Okay, so here again is a look, iliopubic eminence, inferior iliac spine versus superior iliac spine. You have the iliopsoas muscle, and you're gonna put 10 to 20 mLs to get all those articular fibers without getting motor block. So again, vessels, needle, lifting up, it's kind of a fun one to do. You know, it's like gratifying. And like I said, this one has a little data behind it too. So it's been shown to be effective. Again, this is just pointing out the anatomy, that you're on the bone, that you're covering these, just like an IPAC, we're gonna cover these articular branches that come off of those big nerves. So these big nerves are gonna send articular branches that you're covering. So that's the PENG. It's like an 18 megahertz probe. That's what 18 megahertz image looks like. All right. It will be easier pre-op. just bandages on, and it's, you know, it's easier pre-op. Yeah, I always have like a tendency to do things post-op because I want them to last longer into the night. The surgery is 3 hours. I've lost 3 hours off of a 12-hour block, but certain ones I'll try to get to before, like an IPAC I'm going to do before. All right, so. And just to point out, you could do an isolated femoral block and then go after the lateral femorocutaneous. So here's one slide at just going after the lateral femorocutaneous. So we have our, this is lateral and this is medial. So we have that, remember we have the iliopsoas here, then we move lateral, we see the big sartorius, and then the next muscle is the tensor fascia lata. In between there, outside the fascia iliaca is lateral femorocutaneous nerve. So you could just find it, put a couple mLs by it, and be done. That would be an isolated lateral femorocutaneous block. Maybe you could do that for a skin graft or something on the lateral thigh. All right, let's dive into the sciatic nerve. So these are osteotomes and dermatomes and the muscular innervation. So the sciatic, you can see, misses this anterior medial knee, which is why the femoral and the adductor we use for that. But you can see that like most of the tibial plateau in all the tibia, you know, I mean, the question is the saphenous have osteotomes? This picture shows it as such. So I would say there are some contributions of the saphenous to the bone. But for the most part, the lower leg, doing a BKA or whatever, the popliteal, the sciatic is where it's at. So again, anything up here that's not covered is a little bit of obturator or femoral. And the back of the thigh up here is posterior cutaneous nerve of the thigh. And which is basically branches of the sciatic, but it comes off up high. So if you did a low sciatic, let's say I blocked the sciatic mid-femur, I would miss the skin on this area. This is not a common operative area, you know, but I would have to do a subgluteal or a labat sciatic in order to get that posterior cutaneous nerve of the thigh. In general, though, we have our labat here, Raj technique here, mid-femur, and popliteal. And then you can even do isolated branch blocks. So foot and ankle surgery, amputation, posterior compartment of the knee. This has been a real lifesaver for me at like 3 a.m. at Wayne with a DKA patient with a bicarb of 9 who I did not want to put to sleep. And I just get them on their side and put 30 mLs around there and do the case, you know, for a guillotine DKA, what I'm describing 3 weeks ago. But it really got me off the hook. Trauma patient, and they're coming up and they have this distal extremity injury. You don't know anything about it. You hear like a loud systolic murmur, you think it might be critical AS or something like that. This is a no-brainer. Like it's an easy way out of a tricky situation. So this is a cadaveric dissection that I did, and I took a picture because I wanted to point out that subgluteally, this is proximal distal, that it's really 2 nerves. You know, you think of it as the sciatic nerve, but it's really the posterior tibial common all the way up. But it is wrapped in a paraneurium. The paraneurium is a sheath outside the epineurium that allows the nerve to slide inside when you're bending your knee or when you're moving, so it glides and prevents it from having the inability to glide. So down here, this is your posterior tibial and your common, and you see this connection between the 2 nerves there. That is the paraneurium, and I'm going to talk about popliteal and how you really have to be in the paraneurium in order to get a good block. So the sciatic nerve is 2 major trunks, tibial and common peroneal, L4 to S3. So remember, we're T12 to L5 for the lumbar plexus. This is now the sciatic nerve, L4 to S3, lumbar and sacral plexus. The sciatic nerve enters the pelvis with the posterior cutaneous nerve of the thigh through the sciatic foramen deep to the piriformis muscle. Bringing back some med school memories, right? So you got your notch, the nerve goes through, under the piriformis, sometimes through the piriformis, people that have piriformis syndrome, which is sciatica from piriformis muscle hurting the nerve. And then it passes between the greater choke and ischial tuberosity. These are 2 landmarks you can feel on yourself, right? Like the greater choke and the ischial tuberosity. Right in the middle of there is a huge nerve. So when you're like looking for with ultrasound, like it's like All right, there's the ischial tuberosity. There's the greater trode. Right in the middle, with my curvilinear probe, I'm going to see a nerve this big, like this big. You know, it's like not like this big. It's like this big. So you can find it. But how you find it is you push hard with the probe and you change your angle. That's called angle of inclination because nerves are like an accordion. They're not like one plane. So if you change your angle, it'll pop out at you. And the other thing is to scan up and down pretty fast because if you are in one spot, your brain just sees tissue. But if you scan up and down, you see this continuous structure. And I remember struggling with the popliteal trying to find the nerve, but now it pops right out at me. And a lot of it has to do with pushing hard, changing the angle, moving up and down, finding it. So here's a look at the sciatic nerve, yellow and green. The two nerves kind of forming together. And then you have these other sacral nerves over here, pudendal. Pudendal kind of comes out with sciatic. In some sciatic techniques, you will get the pudendal, which will give you a numb perineum, which is good to warn the patient about. But that's very high block. I don't teach that, and I don't think you'll see that. All right, so this is like super board relevant. You're gonna have questions. It's just so easy to ask these kind of questions that they do it every year. So we have obturator here in the blue, maybe a little L1 ilioinguinal up top by the scrotum there, or femoral, lateral femorocutaneous, and then the sciatic nerve being, you know, superficial peroneal, deep peroneal, sural, and saphenous. So saphenous, they're gonna ask a question. I guarantee you on your writtens that like they're doing foot surgery and which nerve is not involved in the toe surgery, and it's going to be saphenous. So saphenous goes to the medial mount. It can enter the foot a touch, but really the distal foot questions are going to be saphenous is going to be the one that's not down there. Now the bottom of the foot has the calcaneal, plantar, sural. Those are all off the sciatic. So if your sciatic nerve, common peroneal, becomes superficial and deep. They like to ask how the web between the first two toes is the deep peroneal. The top of the foot is superficial. Then the bottom of the foot is calcaneal by the calcaneal bone, plantar on the bottom of the foot, and sural on that lateral aspect, with saphenous being medial tibia down to the medial mount. I think that's bread and butter stuff. All right, your approach is to sciatic nerve. So I'm doing an AKA. This is my go-to, as long as they don't have a very big rear end. If they have big gluteus maximus, minimus, it's going to be hard to see. But most patients that come for AKA are not real heavy on those. And this is AKA block, like that's where I'm using this. AKA patients are very sick. Think about it. The legs dead. So it means that they're not doing well. So the AKA patients, you really don't want to put to sleep. And I can't remember the last AKA patient I put to sleep. Probably my last 30. And this was a big, when I was at another hospital where I didn't have good support services. There's nobody around. These cases were invariably at 5 p.m. I really didn't want to get in big trouble with a patient. So I would just give them 10 milligrams of ketamine, 1 cc of propofol, put them on their side, put on a gown, because you got to get like up in there. And curvilinear probe, push in there, feel the greater trode and the ischial tuberosity, look for a big old nerve and whack it. And I'm not too worried about it because it's like, what are you going to get? You know, foot drop? No, they're doing AKA. So I can be aggressive here. I need that block to work. If I have an 18-year-old pitcher getting elbow surgery, I might not even block them at all because I don't want any risk of paresthesias or pain, or I may do it and not be aggressive. But this one I'm going to be aggressive because I don't want to put this guy who's got a valve area at 0.6 to sleep. So this is the greater trode ischial tuberosity, and right in the middle is a big old nerve. And you want to do what we call the donut sign. Donut sign means the nerve is floating. All right, so that's the Raj. This is the Labat. So there's a line you draw from the PSIS to the greater trode, and then in the middle, 90-degree for, you know, right angle down 4 centimeters, you drop your needle in. So it's like you take a marker and you draw from here to here, and then 4 centimeters down off the middle, that's where the nerve is going to be. This is a deep one. we use a twitch monitor. You see a foot twitch, you use your curvilinear. I don't go after this too much because I find it to be deep. I find the raj to be easier. You're more likely though to get the posterior cutaneous nerve of the thigh, but that's not like a huge pain generator for surgery. If you have them running colonoscopy deep on propofol, you know, if everyone says, "Oh, I did a block," okay, I'm done. Start, you know, checking their email. No, you got to get this kicking in. It's diffusing to the axons at the center of the nerve. So I make them colonoscopy deep, right? So everyone know what that means? Like basically, not moderate sedation, you know, but you give them propofol until they're not really grimacing when you push on their mandible. You know, like that's colonoscopy deep. There's EGD deep, which is a step further, right, where there's no gag with the scope going in, but colonoscopy deep. Because even if they're numb in what you blocked, let's say it's a wrist case and they're going to hang the finger in that Chinese finger trap thing, you know, like it's pulling on their shoulder and they might be like, ah, you know, and then the whole room is like, oh my God, it's not working. It's working, but you know, it's wide awake. So I get, you know, run a little propofol, 50, and then give 1 and 1, whatever it takes. All right, let's move on to the IPAC. So the IPAC is an effective way to get the posterior capsule. So total knee replacement, 65% of the pain is from the femoral nerve. So that leaves a chunk that's not femoral. And that's the posterior capsule, which is innervated by the posterior branch of the obturator and the tibial nerves. And what we noticed is like you would do your adductor, patients would look great, and then they would start to say, I got a little achiness behind the knee. That was a common theme. So we started doing popliteal blocks for total knees, but they got a foot drop from it and freaked the surgeons out. You know, in a valgus knee, like 1 in 50 knees get a foot drop, so surgeons are already nervous about it. And so if they see the foot not moving post-op, they don't like that. Plus, the patient can trip because you can't pick your toes up. And we want this patient to go home. So we got away from popliteal blocks, and in came the IPAC block. Now, the IPAC block is effective, but it probably doesn't last forever. You know, it's like putting Ropey or BP sub-Q, it's going to last 6 hours. And so, is it a game changer? I don't know. But the posterior capsule infiltration by the surgeon, called local infiltrative analgesia, that covers these same fibers. And that's why we kind of got away with this, because there's a downside to this. There's some case reports of injuring the popliteal artery. You know, the superficial femoral becomes the popliteal, and that's the only innervation to the lower leg. So if you cut that with a total knee replacement, they saw it, like you lose the leg. So if we could damage that with this technique, that's a downside. And that makes me, that's why I'm always like, where's your needle? Where's your needle? Don't advance until I see your needle. Like you see me, like I grab your hand, I'm like, wait, show me the needle. You know, don't be fishing around. First you find your needle and you follow your needle and you cannot cause harm. But if you like get in there and then find your needle, you could be somewhere bad, intrathecally, intrapleural, intravascular. So anyway, this is the posterior tibial and the common peroneal, and you see these branches. They call this the popliteal plexus. The popliteal plexus goes and innervates the back of the knee. So this is the femur. This is everyone feel their leg. There's 2 groups of muscles. There's the biceps femoris on the lateral side, big old tendon. And on the medial side is the semimembranosus tendinosus, right? Those are your hamstring muscles. And you have the vein and artery and the nerves. This is the bone. In the bone, you could be at the condyles or you could be at the metaphysis, and that's going to become important. So I prefer this lateral. Some people do it frog leg. Curvilinear, because you get a view of the whole thing rather than chasing your needle, but you could use either. And when you're distal, you see these 2 condyles. So you start there. Okay, that's my condyles. And then you move proximal until you see it more straight. You see the difference there between condyles and straight? That's the metaphysis. You get diaphysis, metaphysis, condyles. So this is the metaphysis. You don't want to be where it's circular, the diaphysis. You want to be where it's metaphysis. And then our needle will come in between the bone and the vessels. So it's just important to see the vessels, to see the bone, and go between there and inject 10 mLs of 0.2 Ropi on the way out. Right, again, there's popliteal plexus, needle trajectory. This is the frog leg in the different views, diapasis, more metapasis. I get confused with this view. I struggle with it. I'd rather do it lateral. All right, now there's something called the anterior sciatic. If you ever want to learn this, I think Mekian does this one. So from the front, you see the vessels and the bone and the nerve. And you drop your needle down between the two, or you come in this way. Now being anterior posterior sciatic. And that's good. You got a big, heavy patient who's not able to get on their side. It's quick and easy, but just another approach. All right, let's talk about the POP. So POP is probably the most common lower extremity block besides adductor that you'll be doing. And you can cause harm with this block. So you have to be careful. Like, no block is worth a lifetime of injury. Every single block you do, say to yourself, like, it's a never event. I cannot cause harm. I can't. Foot drop for life, chronic neuropathic pain, it can't happen. So you need to see that your needle is not inside the nerve. Like, that's the bottom line. So this is a great representation of the paraneurium right here. So you have the two nerves wrapped in the paraneurium. And you have popliteal fossa down here, that's like your knee. And then as you go up higher, you're gonna have to pick a spot where to block it. Now, way up here, you're not gonna be able to get in between the two. And way down here, the nerves are too spread out. So you wanna find right when they bifurcate, go through the paraneurium, and think of it as a pair of pants. So common peroneal, posterior tibial. Even if I inject a little bit on my left leg, it's gonna spread up and go over and go down the other nerve. So it's like a sock, like a sheet spread's gonna go up and down. So here is a picture of a peripheral nerve. So you have board stuff, right? So you have fascicles. Fascicles are a bunch of axons. Each fascicle is wrapped in a paraneurium. The outside is called the epineurium. So that's a peripheral nerve. But now there's this other sheet outside of both nerves called the paraneurium. And we're going to inject in between the two peripheral nerves inside the paraneurium, 20 to 30 mLs. So I prefer them on their side, but you can do this supine with the leg on a Mayo. You can do it lateral, or you can do it prone. Patient's wide awake pre-op, go on your belly real quick. Take a good look. That's nice and easy. But for me, I like a draw sheet under the patient. I tell the patient to reach for the bed rail with the operative side arm. And as they're reaching, I pull the draw sheet and it gets them right on their hip, and then they're lateral. Even a big patient, it's really easy to get them on their side. You say reach for the opposite bed rail, and then you pull the draw sheet. And I usually have a pillow lined up between the knees. Now, when you're scan with your dominant hand, once you find your spot, you grab your probe with your non-dominant hand. You want to have a couple towels where your hand can rest on there. If that hand is very stable, you're going to be much better off. So I always grab like 2 towels, fold them up, scan my dominant hand, put my hand on the towels, and now I have a nice firm fulcrum to prevent myself from moving. So here are the anatomy. Remember I told you to feel your biceps femoris laterally, your semimembranosus and tendinosus, and then your adductor. So this is that posterior compartment of the knee, the medial compartment of the knee, and the anterior compartment of the knee. Here's your popliteal fossa. At there are going to be 2 nerves, so you follow proximally until you find the bifurcation. And that's where you're going to take it. This is posterior approach versus lateral approach. This is a very good opportunity to do a catheter for someone who, let's say you have a heroin addicted patient who's getting a BKA. Perfect opportunity for you to put a catheter. And the catheters are put on the lateral side. They stay very well. Like on the posterior side, they would move with, dislodge, but the lateral side, we'll derma bond over the hole to prevent it from leaking. Some Mastisol, coil it, steri strips. It'll be there for as long as you want it. But you can use Exparel now for popliteal. Exparel is FDA approved for popliteal. The femoral nerve block is almost like historical importance at this point because they found that the adductor block is as effective as the femoral block for knee pain. And since the femoral block gives you quad weakness and 92% of strength is maintained with the adductor canal block, we've gotten away from the femoral block. The other thing is the story I told you about my friend. If I don't go by the femoral nerve, I can't injure it. So I'm going to take 10 times out of 10 an adductor block with you guys. Then I don't have to lose any sleep about the femoral nerve. So you always do the least invasive option that's like equally effective. So this picture at the bottom left of your screen shows how the femoral nerve is all spread out once the common femoral becomes the superficial and deep femoral. So there's anterior and posterior divisions of the femoral nerve. The anterior divisions go down and become the saphenous and the nerve to the vastus. And we want to do this block proximally where the common femoral shows us that we're at the right spot on the femoral nerve for everything to be together. So the anterior divisions supply the motor fibers of the sartorius and pectineus muscle. Posterior divisions descend to the femoral nerve to become the saphenous nerve. So here's a nice drawing just showing the fascial plane. So fascia lata, femoral sheath, fascia iliaca, sartorius, iliopsoas. The nerve is like laying on top of the muscle, and there's like an indentation for the nerve. They've never been separated. You're going to separate them by hydrodissecting them, but there's really no space there. So we use the femoral for anterior medial leg, repair of the quadricep tendon. So quad tendon repairs. Sometimes I'll do a femoral because they have this huge leg immobilizer on all the way up to here, and the femoral's right there, and they're not going to be walking because they're in a leg immobilizer. So I don't have to worry about the quad knees. So the quad tendon repair on a big old guy, I'll do that sometimes. Although the adductor would work, but food for thought. So there's the femoral nerve, is what I just showed you. Then there's the femoral triangle. The femoral triangle is like, I don't know if you ever heard of Scarpa's triangle, but got the sartorius, the adductor, and the ligament. It's this superficial femoral triangle. That's where the nerve is all spread out. And then you have the adductor canal block. So the literature supports the non-inferiority of adductor canal block, which is less quad weakness, but equal analgesia. All right, so let's spend some time on the adductor since you're going to be doing lots of them. Here are the borders, the adductor longus, vastus medialis, and the sartorius muscle. This picture on the bottom right is the sartorius reflected. So there's no sartorius there. And you can see the artery coming down with the saphenous nerve and the nerve to the vastus medialis. And eventually, this is Hunter's canal. It's going to dive behind, the artery is going to dive behind the knee. This purple here is the skin coverage for the saphenous. And in there is the nerve to the vastus medialis, which is some motor fibers to the vastus medialis. And there are cases of vastus medialis atrophy after adductor canal block. So it's something we need to be aware of. And if you want to be safe as possible, you use a twitch monitor. And if you don't have a twitch, you're not on top of the nerve and not skewering it, not causing injury to it. I also have had a colleague at another center tell me that their surgeon noticed more common saphenous neuropraxia and neuropathy, pain at the medial mal and the medial tibia after patients were getting saphenous block. So I think we can be too aggressive. And I think when you have all comers doing these blocks and not usually doing blocks, they're just right in the middle of the nerve, injecting 20 mLs, 10 mLs, causing nerve injury. And so that surgeon, who's very good at a local center, he said, I don't want any more saphenous blocks. I'm just going to local infiltrate analgesia these patients. So keep that in mind. All right, so this is from my Grey's Anatomy. That's not like old book that's all writing. There's like no pictures in it, even though it's an anatomy book. And describing the adductor canal. Because it's like, we should really know the nitty gritty about it if we're going to be doing this, right? So adductor canal is an aponeurotic space in the middle third of the thigh, extending from the apex of Scarpa's triangle to the femoral opening of the adductor magnus muscle. It's bounded externally by the vastus internus, internally by the adductor's longus magnus muscle, and is covered by a strong aponeurosis which extends transversely from the vastus internus across the femoral vessels to the adductor longus and magnus. Lying on which the aponeurosis is the sartorius muscle. Contains the femoral artery, femoral vein, and the saphenous nerve. Here is a bodybuilder showing the sartorius muscle. And then notice the two nerves right here. That's the nerve to the vastus and the saphenous. And they're separated by the vasto-adductor membrane. So one injection will not get both. If you want to get the nerve to the vastus medialis, you have to go fishing for it. But I'm hesitant to tell everyone to go fishing for it because I don't want injury to it. So for me, if I see it, I'll take it. If I don't see it, I'm not fishing for it. I don't want any problems, especially knowing that I gave Celebrex, Decadron, surgeon injected 50 mLs of their Rex solution. Right, Rex solution is a local infiltrative analgesic solution of ropivacaine, epinephrine, clonidine, and ketorolac. And when they inject all around, they inject, the classic LIA technique is to inject subcuticular, where they're going to do incision, medial lateral gutters, posterior capsule, suprapatellar fat pad. And if they do all that, it sort of covers all the stuff that's innervated by the nerve to the vastus medialis and the saphenous and the obturator posterior branch and the tibial branches, articular tibial branches. So there's three compartments. I was saying before, there's the anterior compartment, the medial compartment, and posterior compartment. And these are your borders of the adductor canal, sartorius, adductor longus, vastus medialis. So that's pretty board relevant. But this is just some work I found that says that the nerve to the vastus is part of the pain generating fiber. So if you really want to get, like Jeff Gatson said in the update video I sent to you this morning, they noticed once they went after the nerve to the vastus, they got a little better pain coverage. So both saphenous nerve and nerve to the vastus contribute to the innervation of the anterior medial knee joint and therefore important targets of adductor canal block. Given the site of exit of both nerves in the distal third of the adductor canal, mid portion adductor canal suggested. So you always wonder, because the adductor canal is really the distal third of the leg, and I'm doing this kind of mid femur, so he's agreeing with that here. That Yager sartorius muscle, right, looks like a boat or U-shaped muscle. And as you scan cephalad to caudad, the superficial femoral artery moves from one side to the other. So I've heard Gatson speak, and this guy here is recommending that you want the superficial femoral artery to be right in the middle of the sartorius muscle, and that should be your okay, I'm in the right spot. And the reason he's saying to do it here is that if you go further, the nerves separate. They're even more together up where you see the whale sign, like right below the femoral triangle. And so that's why some people, I know Kirsten goes more north than I do. All right, so the nerve to the vastus is at least as important as the saphenous. At mid-thigh, these nerves are commonly separated by the vasto-adductor membrane and can be several centimeters apart. The nerve to the vastus medialis can be difficult to visualize, and electrical nerve stimulation helps identify it. Placing local next to the artery will block the saphenous, but may spare the MBM. This picture here shows both nerves. The saphenous is right here, and then MBM is here. So what Jeff recommends is to bring the needle to this plane between the vas medialis and the sartorius. Use your twitch monitor to kind of find it, and then open up that space and do a second injection by the saphenous. But again, quick and dirty would just be to go saphenous. And they want you to come in at a flatter angle, so they don't want you like right next to the probe with this one, but maybe come out here and then you can get in that plane better. Otherwise, it's gonna be hard to make a turn once you get in there. This is Brandon Winchester's and Hickman's work where with Indian ink dye, it spreads up and down. So I know we're like, where should we be here or there, but it's gonna spread up and down. So you get good spread. And then this is a dye study that showed that when you put a pretty big amount of local here, as it spreads up, when you get to this area, the cadaveric dissection showed that the dye was here and the femoral nerve was here. So putting a lot of local for an adductor canal block will probably not get you quad weakness more than the nerve to the vas medialis, which is about 8%. So it could be enough to buckle, but I still warn the patients that, you know, get to the side of the bed, get your bearings, stand up, make sure you feel good. You know, you don't just take that first step to go to the bathroom at 2 a.m. and fall. All right, so back to Scarpa's triangle. Triangular space at the apex, which is directed downward. The sides formed externally by the sartorius, internally by the internal margin of the adductor magnus, and then above is the ligament. So here's the whale sign that everyone's talked about. Adductor longus, sartorius, with the artery in the middle. And this is going to be on the higher side. So you're going to use this saphenous block, this adductor canal block for the knee, but you can also use it when you have a bimal and you want to get the medial malleolar coverage or BKA. So it's the other half, it's not the other half, but it's another piece of the lower extremity. All right, so that was fascia iliaca. We did the PENG, the IPAC, the popliteal, the raj and the labat, the adductor, the femoral. That's the lower extremity. I mean, the other thing is ankle blocks, which would be great. Like every time you're doing a silly TMA at 7 p.m. and you're like, this is not the way I anticipated my life to go, you should just ask the surgeon, hey, can I put gloves on and can you show me this block? And they will let you do it. And then once a call, you get an ankle block. And then one day, it's going to save you because you don't have to put someone to sleep. And maybe it's not with a podiatrist, maybe it's with a trauma surgeon, right? So trauma surgeons sometimes have to deal with the feet, and they're not going to know how to do an ankle block. So yes, a podiatrist can do the ankle block or the field block for a TMA, but if you know how to do it, there might be a time when it can help you. Same thing with the ortho guys with the wrist blocks, because you may at some point be able to avoid going to sleep because you did a digital block. Like McGinnis and some distal finger, he can teach you the digital block. And that could save you maybe putting to sleep some critical AS patient because they're working on their pinky. Yeah. But yeah, review those slides and listen to those lectures I sent. And also, Land, I want to make sure I got the keywords done. So that other presentation I put together is just the stuff they ask every year. And I don't need to teach it. You just need to read it. It's straightforward. All right. Have a good day, guys. Nyla, for the cervical plexus block, 5 to 8 mL of 0.25%. That way it leaves them plenty of room to do their own blocks too. Okay. You know, I don't want to, she may not lose the blocks, so she may want